This is a Founding Media podcast.
Hey guys, welcome to Apple a Day Doc Talk. I'm your host, Dr. Ramdeen, and we have a very special episode today. We have Dr. Ruiz here, Andy Ruiz. Hi, Andy.
How are you doing? Good. Thank you for having me.
So he's from Stonegate Pharmacy here in Austin and San Antonio.
Correct.
We have a couple of pharmacies.
Yes, sir.
And what we're going to talk about today is testosterone replacement therapy. This is a very popular topic right now, there's a lot of questions that we're getting asked for in the internal medicine, primary care side of things, and I'm sure you as well, Andy.
Correct.
About this.
All day.
So I wanted to introduce to Andy a little bit here and tell you why we're so lucky to have him today. He is actually a very critical resource to me for hormone replacement therapy and a lot of docs in the area. I know a lot of docs consult with you about things like mode of prescriptions and topical versus sublingual versus injection, and you lecture quite a bit. Just want to tell the audience a little bit about your background, and you're a partner at the Stonegate Pharmacies here in Austin and San Antonio, and co-founder of Endotech Solutions. What's Endotech Solutions?
So Endotech is a platform, a website that we streamline to where it empowers patients to just fill out a questionnaire, and it kind of gives some feedback on where they are on their hormonal status, and then it connects them with providers and pharmacists throughout the United States. And then so it's really a patient empowerment tool.
Excellent. Andy is very, very data-driven. I know that about him. He's always talking about snippets and DNA.
The more data, the better.
Exactly. I totally agree with that. That's why I like him. And Andy attended University of Texas at Austin for 2 years prior to entering the University of Texas at Austin College of Pharmacy, where he earned his Doctor of Pharmacy in 2008. After you finished that, he assisted in the design and implementation of the first combined Master of Science in Pharmacy and Community Pharmacy residency. He was also the first trainee of the American Society of Health System Practices accredited residency. Completed, and after completing that, the combined Master of Science residency program, you joined an independent pharmacy in San Antonio, where you were the wellness director and pharmacist in charge, right, of a closed-door specialty and home infusion pharmacy.
Correct. We did it all.
Yeah, it's not even a third of the way through the way I'm introducing you here, but in May of 2011, Andy moved to Austin here, and soon after assumed his role as a business partner and pharmacist in charge at Stonegate Pharmacy. And as president, Andy oversees all operations of the Stonegate Pharmacies. He enjoys teaching academic, intraprofessionally, and at the University of Texas at Austin College of Pharmacy, he teaches both elective and didactic courses as an adjunct assistant professor. And Dr. Ruiz also serves as an adjunct assistant professor for Midwestern University College of Pharmacy and faculty preceptor for Incarnate Word University Fike School of Pharmacy. Are you getting tired, Andy?
I got 2 kids now, so very
In addition, Andy lectures for various chemical companies on hormone replacement therapy for men and women, and he's a fellow and serves as an instructor for the American College of Apothecaries, where he teaches advanced courses in men's and women's health. And just to give you a little bit of his research background, in 2010, Andy published his original research on bioidentical hormones, which is very common question right now about what is bioidentical, and we'll get into that. But prior to 2010, Andy published original research on infectious disease, served on the board of the International Academy of Compounding Pharmacists Foundation, and served as the foundation's research committee chair. He's currently a member of the National Community Pharmacist Association, Texas Pharmacy Association, American College of Apothecaries, and Alliance of Independent Pharmacists of Texas. Andy is also active in research, and his current research is focused on safety and efficacy of various routes of administration for bioidentical hormone replacement therapy in menopausal women. And he's hoping to start a new study on the utility of sublingual hormone replacement therapy.
You can joke, and my head's like going like this, so you feel free.
Having said all that, you can see why I feel really lucky to have Andy here today. That's all we're talking about today is hormone replacement, specifically with testosterone in men and women. If there's anybody I wanted to talk to about this, it was you, Andy. Absolutely. Not only because of your background, but I know that just locally you are the main resource for this among us
Well,
physicians.
you have to work with the best. You practice what you preach, and I can't do the things that I want to do if I don't get to work with the best and brightest out there. So I appreciate being here, first and foremost.
Thank you so much, Andy. And let's dive into it. And the first question I have, one of the most common questions, especially when someone is a candidate or wondering if they're a candidate for testosterone, one of the first questions I get is, what does bioidentical mean?
That's a great question because, when I was first doing my research back in 2008 on, what we call bioidentical hormones, I was pretty lambasted for using that term because, it's the best term that we use more, or I guess very openly. However, if you want to get scientific, isomolecular would maybe be a better term, or natural hormones. But to be fair, they're still synthesized as most things that we have in our day-to-day lives. So it's not like I get your hormones, pull them out of your blood and give them to somebody else.
Right.
The reality is they're still chemically made in a lab, and they have to meet certain standards of purity to even be utilized. But all that the bioidentical hormones really mean are natural hormones that are identical to the hormones that our body produces. And our job as pharmacists is to advise and prepare medications that they can be utilized in the most physiological or natural means possible for your body. So this way, they're metabolized properly, they're absorbed properly, and they're utilized properly throughout the body.
So basically, the more they look like the real thing, the more they'll act like the real thing.
Exactly.
And can you tell me what the difference is between bioidentical testosterone, let's say, and testosterone maybe that are not labeled?
Yeah, so let's use and there's a lot of natural hormone replacement therapy out there that is commercially available. So when I mean commercially available, it's something that a big pharmaceutical company would make versus what we make are custom medications, right? Or compounded medications. And so as anybody's wondering what is a compounded medication or what's compounding, ask your grandparents what an apothecary is or Google apothecary, and you'll see this older gentleman in a white coat, generally not behind glass like we do now, or doors and a HEPA filter and whatnot now. But you see them mixing things, and that's, for lack of better words, we're making things from scratch. But, the bioidentical hormones come in commercially available forms like Vivel-Dot, which is an estradiol patch, or they can be compounded. So there's different means, but when we discuss the commercially available non-bioidentical, you have cypionate, right? Let's just use testosterone cypionate. It was injection that's commercially available.
By the way, that's one of the most common routes of administration.
Is that injection? And if you think about it, what the biggest difference is that cypionate has it's called a conjugate. So it's a salt form that's attached to it that your body has to cleave off, right? That's not necessarily bad. If you think of B vitamins, they have to be activated. It's a similar fashion with testosterone cypionate. It has to be activated. The only caveat that you come into these types of parameters is if you think of the difference between estrogen and testosterone, if I had a picture, I could show you the difference, which is almost, if you'd look at it, you'd think it's the same. For the layperson, almost 100% of the time, it's like, oh, it's exactly the same. But those small changes in those molecular structures can generally have a significant effect throughout the body. So our methodology with using bioidenticals is let's use exactly what the body produces, so this way we can provide that same natural outcome versus relying on genetic factors or bacteria to cleave and break off these conjugates, which that's a whole different topic. But we start talking about the genetics and
really
biogenomics.
So basically what you're saying is with bioidentical, you basically have these patients bypass a step towards
a simplification.
Effect.
Right. So let's just keep it simple.
Okay.
And which is, let's not rely on the body to activate things if unneeded.
So let's say there's a patient that's deciding between a bioidentical here or a non-bioidentical there, and they're looking at price maybe, and they're wondering, okay, if I do this formulation that's not bioidentical, and I have to quote, cleave that salt group off myself. What are some of the concerns, or what should patients look out for? Who would be the types of patients that may not do as well because they did not choose the bioidentical?
So in some cases, if they have microbiome, so gut digestive issues, sometimes, which you're thinking, well, you're giving me an injection. Why would that matter?
Right.
We rely on the bacteria in our GI system to really convert a lot of hormones over and to recycle these hormones, right? So if you're having GI issues, that could be a factor. In some cases, if you don't metabolize the hormones properly. So if you have, we refer to as MTHFR conditions or other genetic factors, they may not be as rapid converter. So it may stick around a little bit longer, or they may not utilize it as efficiency, or in some cases, they may convert it more rapidly over to estrogen.
That's an important point, isn't it, Andy, where the testosterone you take is peripherally converted or just transformed into estradiol, which is an estrogen. And what you're saying is you don't want that to happen too quickly, because then you're going to have the exact opposite effects of the testosterone.
Correct. And so for you guys out there that are like, man, I've been on testosterone and I felt like a rock star maybe for the first 2 weeks, maybe the first month, and all of a sudden you had this regression, there's a good chance it's converting over to estrogen, or it's not being metabolized appropriately. And we may talk about these things rather off the cuff or, simplified, but these are pretty advanced topics that, as Dr. Ramdeen was saying, that we're still learning, we're still evolving, the literature's still coming out. So how do we properly address these things? So it's important to empower yourself and to really start, looking into what is my health, what is my genomics, how am I eating?
Right. Since we're taking a deep dive here, I know we're on a tangent, but it's a really important question I get is, let's say you have someone, the testosterone level looks great, they're doing well otherwise, but now their estradiol's creeping up, and they might need to be on a blocker to prevent that. Talk about what medication options they have.
Yeah. So so I've had myself personally, like Dr. Ramdeen was beautifully putting how I take on more than I should at times with the intro. Stress can be something that induces our aromatization, right? So meaning that it converts over testosterone to estrogen. And I myself have been a victim to that in the sense that it's self-inflicted. And in a lot of cases, let's be real, it's not something that I can just go sit on the beach for a month or just relax, and it sounds nice, but there's reality here. But at the same time, as we convert over more testosterone to estrogen, one of the natural properties of estrogen is we crave sugars. It induces fat deposits in our lower abdomen, upper hip. So it's this adding fuel to the fire that's just not easily just take the bull by the horns kind of concept. You have to be active and conscious of the decisions we're making to further address this. And in some cases, medications are very necessary. So, we see medications like anastrozole or letrozole. And what these are, they're called aromatase inhibitors, right? So you're preventing the conversion of testosterone to estrogen. However, like Dr. Ramdeen was alluding to, estrogen is very important in men as well as women. So in men, if we drop our estradiol too rapidly or too much, it may prevent ejaculation. It may prevent climax. It could cause lower lumbar osteopenia. Osteoporosis in our lower back kind of thing. So these medications are important, but under the supervision of a skilled practitioner such as Dr. Ramdeen, that we want to make sure that we're keeping a close eye on these things. We're not just buying them off the internet and popping them because I'm trying to lean up, because the outcomes can be rather detrimental from even a cardiovascular perspective. So
in decreasing your estrogen too much. And basically what you're saying, Andy, is that obviously you don't want your estrogen level to be high or estradiol level to be high, but you don't want to overdo it in suppressing its formation.
Correct.
And the best way to do that would be to use the lowest possible dose as infrequently as possible.
You got it.
So you don't just blast it down, see a low estradiol level, and be like, yep, we're good on this dose.
You nailed it. It's the whole start low and go slow philosophy.
Yes.
So we're fine-tuning it. And that's where... our society as a whole may kind of work against us, that instant gratification. Some things that are worth it are worth waiting for. So as we titrate up, to be patient, to be understanding that this is a process.
And is there a dose and frequency you find work well for men and women to start like an aromatase inhibitor?
That's a great question because first and foremost, there are certain products that are out there that are natural supplements that are touted for blocking aromatization. And the natural supplements are out there. Truthfully, while there's been some anecdotes, and you'll see it all over the website, all over the internet, there have not been proven to be effective in the literature. So,
can you give us some examples of the natural?
So I'm thinking as I'm talking, right? The one I'm thinking of comes from passion flower. Chrysin. Yep. I was like, what is this one? Chrysin. So it is advertised all over the internet, all over the health stores. The reality is, so one of the courses I used to teach was the supplements course for men's health. And I wanted passionately to prove that there is something out there that works. It's natural like that. And I could not find it. So I had a bias, right? I'm like, it's got to work. There's got to be something. Like let's use chrysin as an example. I'd rather leave that beautiful flower of a passion fruit alone rather than destroy it to get chrysin. Because what the research has shown that while it works in vitro studies, meaning in a petri dish where they destroy the cell membrane, expose the inner enzymatic reactions, it doesn't work in humans or in vivo, right? That's when you read in vivo studies. So when that happened, tons of research showed, well, in human body, you either don't absorb it or it's not working. So the reality is those natural supplements haven't really been shown to be effective with regard to stopping aromatization.
Can you talk about DIM a little bit too, Andy, and how this falls into
I was just going to say DIM and some of the other...
and what does that stand for? Do you know?
So it's a diindustol of...
It's okay.
It's a concentrated broccoli extract.
Right.
And it has an inositol in it component, which... You'll see more and more come out, such as choline as well, right? So choline meaning found in eggs. You find high concentrations of inositol and derivatives thereof in broccoli. And what those do is they really do help the estrogen go down the proper channels. And what I mean by channels is as your body's metabolizing these hormones, think of it as a fork, right? So if it's a fork facing downwards and the hormones are being metabolized down, specifically estradiol, right? The most physiologically active estrogen in both men and women. You want it to go down that left pathway, that 2-hydroxy pathway. And that pathway is initiated by DIM. So DIM is a great starting tool in going down that pathway. As that pathway veers off to that left fork with a healthy side, it splits again. So here's where the other cofactors that you were alluding to come into place, such as manganese, such as copper, such as N-acetylcysteine or cysteine, which is another essential amino acid throughout our whole absorption of green leafy vegetables, right? So this is where this whole eating healthy comes into play. Because if you think about Brussels sprouts or spinach or any other green leafy vegetable that is grown in the dirt, it's absorbing these nutrients such as manganese, copper, zinc, selenium. The list can go on and on of all these B vitamins that are just grown and nourished and really amplified in these vegetables. So it's important to eat as much of that as possible, but supplementing our diet with those things as well to ensure that we're having the proper metabolism. So this is where that genomic aspect comes into play in the larger complexity of what we'll refer to as pharmacogenomics of how are we metabolizing our hormones properly. And DIM was a huge groundbreak into that direction, and it's been around for a very long time. And to be fair, we had some idea, but it was positive anecdotes that were accepted in the profession of, hey, DIM works, kind of like ashwagandha. We don't know how it works, but it it does, and someday we'll find out, but this is one of the few that we'll anecdotally recommend. And now the research is just blowing up on it, and it's amazing. And now with such as providers such as Dr. Ramdeen, who can go in and start looking at genomics and identifying your testosterone levels on point. But now we're looking at your genetic factors to understand why you may not be responding ideally, and let's fine-tune those things. And so it's that collaborative effort, that team effort that he was referring to, that we learn from each other.
And that's so important. I talk to Andy all the time, especially when it's a new patient. We do strategize, what's the latest research? What do their genetics look like? What are their levels? And even the mode of administration, which we'll talk about in a little bit. But let's zoom out of the weeds for a little bit so everyone's head can stop hurting and go to a question I wanted to ask too is, who's a good candidate for replacement therapy?
So, the prime candidate that we I guess textbook candidate, right, would be a male, generally let's just say testosterone, generally over the age of 55, that has a serum testosterone, total testosterone under 300, and expresses certain symptomatology, which will also get a free testosterone on, right? Reality, right? There's various ranges of candidates, and it can be as young as the 30s when that individual is really entering their professional careers and lives, and stress is catching up with them, age is catching up with them. And I always joke that once I pass 30, that's when I noticed things were starting to change. So it was it's really hard to identify, to be fair. On how to treat them, even. I'm sure when you're seeing the patients, and you're like, this individual screaming low testosterone.
And you're right. The reason why it's so hard to answer is because this is a multifactorial assessment. It's not just, your number's 299, boom, testosterone, right? So, because there's a range. It's about 300 to 800, and there's, symptoms like low libido, low energy, loss of lean muscle mass, increased fat, concentration difficulties. There's plus, the number that you see.
Exactly.
So they really do have to put the whole picture together.
You nailed it.
And aside from that, looking at risk factors like, do they have really bad uncontrolled sleep apnea? Do they have blood clots, DVTs, PEs, prostate issues? That might preclude you, at least temporarily, until you get those things under control, from doing that. So it is not just, here's your number and here's your testosterone. You really do have to look at everything.
Correct. And take the healthcare into your own hands, because providers such as Dr. Ramdeen can only do so much. They can provide the tools to patients as myself when I experience these things. But if I didn't take the proverbial bull by its horns, or life under control, then his hands are tied. So it is a true team, not just pharmacist, physician, nurse practitioner, whoever it may be, but truly the patient being in the center of that team, because they're the quarterback, if you will, of how we're going to go with things.
Absolutely. And you mentioned men, but this is growing in terms of use for women too, right?
Definitely.
Talk about that.
So, just like estrogen in men, at first it was like, why would you even talk about that, right? But it is very important in men. But same thing with women. If their testosterone, so let's just simply put, as a woman goes through menopause, their ovaries cease to function, right? So testosterone is produced in the ovaries. Without testosterone, their cardiovascular disease risk goes up. Their sex life is their quality of life in general is just affected as well. So that affects their relationships. So it's not just about male and testosterone and their libido, right? That also has an effect in women's health too. So you and I have talked about that. You can't necessarily try to fix one without helping fix the other. So in women, you're seeing all different types of forms being utilized for testosterone, whether it be an injection or sublingual or a pellet or a cream. There's just been all different forms and avenues for treatment of these conditions as well that are just being utilized significantly. Right.
And so I just wanted to mention that this is a problem that women have too, and it's
and it wasn't too taboo, but maybe even 5 years ago it was like, okay, it's coming out. Where is this going? What does this mean? But it's been pretty established and pretty throughout the medical literature and as well as in the healthcare community that this is important, that we just have to properly work it up and monitor it with skilled providers such as Dr. Ramdeen.
Right. And so what are we talked about some of the risks, but obviously benefits, and I wanted to reiterate the risks. If you are thinking about doing this or already on it, you really should know about your prostate health. I like to check a PSA or a prostate level on your blood test. If it's going up, then we're going to have to either reduce it, stop it, have you see a urologist. And if you have sleep apnea and it's not controlled, or if it was previously controlled and now you're on testosterone and that's getting worse, that's another red flag that we need to kind of pull back or pause what we're doing. And then
that's a great point, though, because a lot of men think testosterone fixes my sleep apnea. It can also have the opposite effect, like you're saying. So that's a great point that you brought up.
Right. With the testosterone, you can have weight loss, which would be beneficial for your sleep apnea, but it can also harm you. And stimulation of erythropoiesis, it thickens your blood, increases your hemoglobin and hematocrit, and that can cause you to have blood clots, DVTs in your legs, or blood clots in your lungs, or a pulmonary embolism. So if you've already had those things, or you're predisposed to having those things, these are definitely something you need to go over with your doc.
Correct.
Or even cancers, like estrogen receptor positive breast cancers, for example. If you're going to be converting that testosterone to estradiol, and now your estrogen levels are high, you don't want to run that risk and not tell your doctor in advance.
Exactly.
You may not even be a candidate to tell you the truth.
Well, and what's interesting is this is where I think these genetic tests are coming into play, even for men, is I learned I was a carrier for breast cancer. And, you don't think of that in men generally, but men can develop breast cancer. But at the same time, what if I have a daughter? Does she inherit those genes? Does she inherit that risk? So it is important to think about the immediate, but as well as long-term effects, and discussing that with your doctor, your provider, and to really understand, hey, where am I in this whole spider web of endocrine? And am I a candidate for testosterone or any hormones in general for it? And if not, what can be done? And
let's talk about the benefits now. So why take it?
Well, as like I said earlier, testosterone, let's just say it improves the overall quality of life. But it also helps overall with cardiovascular disease, osteoporosis. And so the effects that it has are broad reaching. Not to mention that if you take away testosterone, in men specifically, you generally take away estrogen. So it's not just so colorectal cancer goes up. So you really have to think about how does this affect the overall state of the body, because they have an intricate working relationship. I mean, it's almost like the holy trinity with the estradiol, testosterone, and progesterone, because progesterone is critical in men as well.
Right.
So we don't really think of those interactions together, but those three together either convert or interact with each other.
Right. So. And what I like what you're saying again here too, Andy, is because we're trying to educate on this, but it's still very complicated, right? And so you need to look at everything. And one thing I'll just say as a side note is that sometimes people are doing this without any medical supervision. They're getting testosterone from a friend or something like that. Obviously, we don't want you to do that.
Correct.
But when someone like that comes in, obviously have them stop it, because there's other labs that are off. Their cholesterol may be off, their liver function, their kidney function, their estradiol may be off the charts. And I actually got a call from a colleague last weekend who's a hospitalist, and they know that I this is all I do all day. So they called me because a young guy is in his early 50s, had a stroke, testosterone level was off the charts, was getting it from his friend, and so there we go with that stimulation of the erythropoiesis.
Correct.
Causing your blood to clot, and it may manifest as a heart attack. Not that it causes cardiovascular disease, but it can totally block off that blood vessel that's feeding your heart.
Correct.
And that can happen anywhere. It can happen in your brain, can be a stroke. So you do not want to do this and say, oh, my testosterone level is great. There's so many other things that we need to look out for when you're done.
Exactly. And for men, I mean, let's get real. Like he's saying, it can start anywhere. Think of your microvascular. ED generally is a first sign of a microvascular concern. So if you're taking testosterone, it's uncontrolled, it's unsupervised, it can lead to ED in some regard if you're thickening your blood and it clogs up that microvasculature. So if that's what'll help you think about, hey, maybe I need to go see a doctor, please. This is a risk. So let's just get real there.
And when you say microvascular, it's those little blood vessels,
little
right?
tiny blood vessels.
And exactly. And so I just want to stress. Just want to stress the importance of monitoring and not just saying, okay, I'm taking testosterone. I went to some random lab. My testosterone level's high. I feel awesome.
Right.
No.
Right.
That is not the whole story. And you may get really permanently hurt yourself if you have a stroke or a heart attack. And we just don't want you to do that.
And you nailed it. And you know, for myself, like, I'm a young guy. I go see my provider regularly, and I talk to my family, and they're like, "You're healthy. What's the deal?" And it's because it's important to just monitor, to be taken care of, and to ensure that overall health is being supervised.
Absolutely. And you alluded to the modes of therapy, Andy. Can you talk about the different ways testosterone can be administered?
Yeah, the most common, I'd say, are injection, creams, and sublingual tablets now, or buccals, what we'll call them, where you put them in either between your cheek or under your tongue. And when I say injection, that can even include a pellet to just simplify the overall.
Sure.
But the most common probably right now is injection.
When you do the topical routes, do you feel like absorption issues or is absorption an issue in terms of lab monitoring?
It totally that's a can of worms.
Yeah.
I like that question. So if done properly, we can overcome these barriers to some regard, but the skin is a barrier. The skin is designed to protect and keep things in and out. So when we put things on our skin intending to absorb in, we have to understand we're trying to bypass a barrier, the biggest organ in our body. So I'm not a massive fan of topical. That's how I first started, though. So I have utmost respect for that route of delivery. And in some cases, it works phenomenal. But that's where I take the cues from the patient, because if that's the route they want, then that's kind of what we're going with. And that's our job is when you say, hey, they want this, here's their level, what can we do? We try to figure out how can we bypass the skin, how can we penetrate through the skin to get that desired outcome, and educate as much as possible to do the pros and cons of we're going to try our best. If it doesn't work, let's be open to another means.
And one common question I get too, just with the sublingual or the buccal versus injection or pellet, is this going to be harmful to my liver?
That's a great question, because some of the early 1950 studies on methyl testosterone, ironically it was on 3 patients, I believe, had demonstrated liver toxicity when swallowing. The reality is when given in a true buccal or sublingual fashion, it bypasses the liver 100% because of the vascularity in the oral mucosa or our mouths. So we have about conservative 90% absorption. The rest of it is metabolized. We have similar enzymes in our mouth that we do in our stomach that are inert and inactive, and so they don't hurt us. So the absorption is phenomenal, and it is very different from oral. And I think that's something that as patients we all need to understand the difference of that, of sublingual from oral.
Excellent. And talk about the importance of a balanced regimen for optimal outcomes.
No, that's a great point, because even with my provider with extreme stress, if I have sleep disturbances or my life is just full of stress, then I will utilize progesterone because of the neuronal properties of protection that it provides, for the down feeding into testosterone that it provides. So it is important for a balanced regimen. And when I monitor my hormones because of stress, that I may not have too high of testosterone or too low of estrogen or not enough progesterone per se. But that's in men. So thinking about the female body and the complexities of it, of when we're drawing the labs, of when we're looking at these levels, and overall, how is it a balanced regimen to ensure the overall teamwork of these hormones, right? Because they're a team. They're working for us to optimize our health.
And talking about balancing and the intermingling of hormones, just coming up with all these common questions, but particularly men will say, hey, do I need to be on HCG too? Or even women may ask, I heard HCG causes weight loss. Talk about HCG.
So HCG is interesting. In its most simplest terms, it mimics luteinizing hormone, which comes from our pituitary, that both men and women secrete. In men, it stimulates our testes to secrete more testosterone, where here comes the weight loss. That's why women and men who have, in a couple, have done it together, they say, well, my husband's lost more. Well, we're producing more testosterone, and generally we have a higher metabolic effect with that regard. And women, chances are if they've gone through menopause, the HCG would have minimal effectiveness. Whereas if they're still ovulating, still having a menstrual cycle, you'll have that effectiveness, but we do have to, like you said, monitor the hormones, because what if all of a sudden you're producing too much estrogen, and in comparison to the testosterone, will you have that same weight loss? And that's why some women respond to it better than others. So it's a shotgun approach, and in some regards it'll work, and others we just have to monitor more closely.
My personal thought about, particularly with men asking me this, is are you looking to have more children? Is fertility an issue?
Nailed it.
Because if you're just doing exogenous testosterone or injecting or however the route is, you can shut down, like you said, the testes. And if you're trying to reproduce, trying to have a kid,
can't do that.
Right. So you need to be able to take the HCG becomes critical there to boost your sperm count.
Correct.
And increases your chances of fertility. But if you're not doing that,
right.
if you're not interested in having more children just to do HCG to boost your testosterone, which we can correct by titrating your testosterone dose, doesn't really make much sense to me to add a whole nother agent.
Correct.
A whole nother list
like
of
you
side
nailed
effects.
early. Let's keep it simple.
Right.
Let's start slow and go low and go slow. And you nailed it. We can use testosterone to do that if they're not interested in having children. So, and in some cases we've combined it because some men, and let's not take it for granted, but there's a vanity effect of like, I don't want my testicles to shrink.
Sure.
So then like maybe we combine a little bit of HCG to maintain the testicular function. But like you nailed earlier, let's just keep it simple. I'm a huge fan of keeping things simple.
And what doses do you find work well as a starting point for HCG?
So if it's like symptomatic, low testosterone, but the levels are still technically normal and it's just stress induced, and maybe 500 IUs Monday through Friday or Monday, Wednesday, Friday. It's important to take a break with HCG to allow that pituitary function to kick in and to rebound. You don't want to just shut down your pituitary.
And how often do you recommend cycling like that?
There's some men that'll do it Monday, Wednesday, Friday for a long time, and that is the cycle, right? They're like mini cycles.
Right.
Then there's some men that'll use it Monday through Friday, on a month, off a month, and just go that route. So it's kind of patient specific, like you were saying.
As long as you're giving a break.
A break,
to your pituitary.
correct. Yeah. And then, like you said, for fertility, it may be up to 3,000 IUs.
Yeah.
So it just really depends on the state of that individual and where it's been titrated to.
Right. And finally, I wanted to talk a little bit about any distinctions in your mind that you see between men and women when it comes to testosterone replacement. Is there anything you specifically want women to know or specifically want men to know that may be different?
There's generally a factor of 10 to 100. So if all of a sudden you're getting, well, my doctor prescribed 200 mgs per mil of an injection, generally you're supposed to get 20 mgs per mil. So if you all of a sudden see that this is what and you do a quick search or what have you, and check us, because we're human. We make mistakes. It can get through the pharmacy. It can accidentally be sent over an error, but we help each other. We check each other, but it happens. So check that dose, and don't be scared to ask us. Side effects wise, if all of a sudden you're getting lots of hair, dark thickening hair as a female, that's a concern. If you're starting to all of a sudden have a deeper voice, or testosterone can cause clitoral thickening, right? So if you're applying it to the vaginal area for sexual stimulation, that can happen. So if you're experiencing those, tell your doctor. Men, if we all of a sudden start gaining weight and start having breast enlargement, becoming apathetic, meaning we just don't care, there's a sign we could be converting over to estrogen. Or if we're not urinating properly, our prostate could be becoming inflamed. So tell your provider immediately. So just off the top of the head.
Excellent.
Yeah, those are
one practical question, point that you noted that was important for me is that the concentrations are very different for men and women. So you may have a 200 milligrams per ml concentration of cypionate for a gentleman, but 20 milligrams per ml for a woman. So significantly weaker. But the reason why it's important from a practical standpoint is because, for example, a man might be drawing up 1 ml for an injection, but then you have a woman drawing up 0.15 or 0.0. So if you use a high concentration, just drawing up the correct volume is going to be really difficult. So now they're getting varying doses from week to week, and you don't know how to titrate it. So it's important to go down to a lower concentration so they can drop 1 ml too. Right.
That's where compounding
comes into play. Yeah.
And we're human too. I've worked with some advanced medical specialists that have accidentally, instead of taking 0.25, took 2.5. It happens. And it's the important thing is that we catch it early enough, fix it, and move on to learn from it. But that's where compounding comes into play with really isolating down what's the best mode of administrating the medication. Yeah.
Excellent. Anything else you want to say, Andy, about testosterone, or do you want to maybe join a couple more committees on here?
Definitely. Oh yeah, no, this has been great. I mean, as my mother would say, you can talk for days.
Well, we'll have you back so you can talk some more.
Definitely. No, I appreciate that.
Dr. Andy Ruiz, thank you so much from Stonegate Pharmacies. We'll definitely have him back. I'd like to thank Founding Media for hosting us. Thanks so much, guys, and we'll see you next time.
Thank you very much.